So big news today. We love when a hot paper drops in a major journal focusing on GU oncology, and we get to jump right on it here on GUcast and have a chat to the authors. So today we're going to talk about the PRIME trial, a much anticipated trial of biparametric versus multiparametric MRI, hot off the press, just published in JAMA today, of all places. Apologies from Renu, by the way, she's not with me today. She's in Singapore at a meeting. She was going to dial in, but the times just were not going to work out. Because we did need to go to the UK to be joined by two of the investigators on this trial. It's great to welcome back old friend of the podcast, old friend of us here at Peter Mac in Melbourne, actually, Veeru Kasi, urologist at UCL. Veeru, thanks very much for joining us again on GUcast, and congrats on this big paper.
Thank you, Declan. It's always a pleasure to be back. I'm always looking forward to the next time.
Great. And you're joined by one of your co-investigators, radiologist Francesco Giganti at UCL as well. Francesco is one of the senior radiologists working in MR at UCL. So Francesco, welcome to GUcast.
Thank you, Declan. Thank you guys for having me. It's a pleasure.
Look, great. Congratulations to you, all your co-authors, all the contributing centers, all the patients, of course, involved in the PRIME trial. We'll put a link in the show notes, of course, to the full paper published in JAMA today. But look, it's great to have you on so we can dive into the discussion around, well, the data you're going to reveal to us in the podcast, what it all means. But first, Veeru, I suppose from a urology perspective, I thought it would be good to go back and have a chat a bit about the background to the use of MR in early detection of prostate cancer. It's been a very big part of your own academic career, of course, because you did your PhD on all of this. But from my perspective, here in Australia, MR for patients suspected of having prostate cancer has been a very high standard of care, fully funded for the last 7 or 8 years here. So it's almost unheard of in a country like Australia for a patient not to have an MRI prior to consideration of a prostate biopsy. But that MRI has traditionally been a multiparametric MRI. So I'll hand over to you to just explain to us a bit about, well, what does that mean, or how did we get to this point, indeed, that multiparametric MRI is considered to be such a high standard of care, and then why you set out to test whether we could do maybe a less extensive MRI and still have the same value.
Thanks, Declan. So the work arises from the Precision Group's work, the New England Journal paper where we published the Precision trial, showing that when you have a pathway in men with suspected prostate cancer involving MRI, compared to one without, around a third of men can avoid a biopsy altogether. You have around 12% more significant cancer detected and around the same amount of insignificant cancer avoided. And that paper, as you've described, in Australia and many other health settings, led to a big practice change, and I would argue probably the biggest change in prostate cancer diagnosis for around 30 years since ultrasound was introduced. So following that paper, NICE guidelines, EAU guidelines, US guidelines all changed, but there was one issue. It was around resource and allowing every man who needed a scan to be able to get one. Because when you introduce a new test, there are considerations about how you're actually going to achieve that. You're scanning so many more men, and you then need to have quality control on the MRs and the expertise to interpret it. So there were a few challenges around that. And in our Precision group, which evolved into the PRIME group, what we wanted to do was design a trial where we could evaluate a shortened, more streamlined scan, which was biparametric MRI without contrast, to see whether or not that could become the new standard of care. And if I compare the two together, multiparametric MRI typically consists of 3 sequences: T2-weighted, diffusion-weighted, and contrast-enhanced sequences. That lasts around 30 to 40 minutes. The contrast is gadolinium. It's injected, and then they take sequences from the MRI at intervals afterwards. The biparametric scan avoids the gadolinium contrast injection altogether, but keeps the T2-weighted and diffusion-weighted scans. And that can be reduced to around 15 to 20 minutes. So we wanted to see if this shortened, streamlined version of MRI was as good as the more detailed version, because it would then be able to be used more widely across the world and allow every man who needs a scan to be able to get one.
Yeah, look, that's great. And I suppose, Francesco, from your point of view, doing multiparametric, as Veeru explained, doing the gadolinium, the contrast enhancement towards the end of that does add time. It does add an injection of a contrast agent. So that typically means, of course, we have to be aware of contrast reactions. So certainly here in Australia, that means a doctor has to be physically present. So it limits the amount of time during the day that these scans can be done, or we don't do them at the weekends typically here. And indeed, I think there are still some concerns. Patients come into me and say, I'm not sure about this gadolinium. You read about this gadolinium brain. You'll have to forgive me if I don't know much about this. But some patients specifically come to me and say, I've read about prostate MRI and I don't want to have the contrast injection bit of it. Now, I've been saying to patients, that's no problem at all. It may well be that we don't need that bit of it. But can before we dive into the results of all this, can I ask your perspective for multiparametric MRI and the sort of logistics and the concerns about contrast enhancement?
Yeah, thank you. So basically, as you said, I mean, this is a longer procedure. It requires injection of contrast. And basically, as you said, we have the deposition of gadolinium in the brain in other organs. And this is one of the biggest concerns for patients. I agree with you. Especially actually this, for example, in the active surveillance setting, sometimes they say I need to have repeat MR scans. So, I mean, should I be worried or not, blah, blah. And I do really think that this is a very important trial because it's giving us the first big answer in a very structured and, as we will see, defined study, if we can skip or not contrast. And the reason is that in this way, we will be able to have shorter procedures and also offer MRI to more patients for us. And from an imaging perspective, one of the most important things, and we will see, is the importance of having a good quality MRI, because everything starts from there. We need to have a very good quality MRI and, of course, skilled radiologists in prostate MRI reporting so that we can really take advantage of this technique. So yeah, totally with you, yeah.
So we get it. We get the whole rationale. Sounds like a great idea. Test whether a biparametric, a less extensive MRI without the contrast, could give us the same value in terms of detecting significant cancer. So Veeru, again, the link's in the show notes, but just tell us a bit about the study design and then, what you found.
So PRIME was an international multi-center level 1 evidence non-inferiority diagnostic yield study. It evaluated whether biparametric MRI was non-inferior to multiparametric MRI for clinically significant cancer detection. That's grade group 2 or higher. We carried it out in 22 centers in 12 countries, recruiting around 500 men. And what we showed was that, in fact, biparametric MRI was non-inferior to multiparametric MRI for clinically significant cancer detection, with both detecting around 29% of patients with clinically significant cancer. That was the headline finding.
Yes, look, that's really impressive, isn't it? And I understand it was done within men. So these men were having a multiparametric MRI, but then was it that the radiologists were blinded to the results of biparametric versus adding in the contrast, and that's how you derived the primary endpoint?
Exactly. So these were men who were referred from their community doctor with suspected prostate cancer based on a raised PSA or abnormal digital rectal exam. They were referred to the hospital. In the hospital, they'd have the full multiparametric MRI, but the radiologist was blinded to the contrast sequences when they produced a report. The first report was the biparametric report. Once they submitted that and it was verified, they were then unblinded to the contrast sequences and submitted a second report, including the information from the multiparametric MRI. And any suspicious areas on either the bi or the multiparametric MRI went on to targeted biopsies, and there are also systematic biopsies on MRI negative sides of the prostate.
And if it was an MR lesion, they only had targeted biopsies, I presume, or is that standard of care, or were they having systematic biopsies in addition to the target?
So they only had targeted biopsies from the side that the MRI lesions were run, but on the contralateral side of the prostate, they would all have systematic biopsy too.
Okay, wow. So it's a big deal, isn't it? This is a big deal. So, I'm struggling to think of a reason why, going forward from today, once this paper hits the newsstands, why we would be adding in gadolinium in the early detection setting. We can talk a bit about active surveillance. We can talk a bit about recurrence. That might be different, but surely that's going to be the news coming out of this paper today, Veeru.
Well, having worked on the study and looked through all the images in the MDT, to me, these results are quite convincing. that we could drop the contrast sequence, but providing we have good quality baseline scans and expert radiologists reading them, which I think goes hand in hand with using MRI in the first place. So yeah, I think we could move to a biparametric MRI approach.
I think that's the headline. But Francesco, one of the things I know people still have concerns about, and Veeru's hinted at it, is quality. Having high quality acquisition of MR is still very important because we put a lot of trust now in MR. Can I ask you about the quality metrics within the trial? I recall in the precision trial there were central reads going on. And I think there was quite high concordance. Was it about 80% or so? Did you have a similar sort of central review going on for these scans in the PRIME trial?
Yeah, so basically, as Veeru said, we started this study building on the expertise gained from Precision, so from the Precision trial. And actually from the Precision trial, we also created a dedicated scoring systems a few years ago called the PI, and which has now undergone a major overhaul. Now we have version 2. Basically, this scoring system is a system that allows you to evaluate the quality of your scan. And so based on that expertise, then we carried out a quality assessment of the scans before starting the PRIME study. And we published the data 2 years ago, called the Glimpse study. Basically, what we saw was that basically we asked all the centers who wanted to participate to this study to submit their own scans. We evaluated the quality centrally, and then we gave some hints and to improve their quality and their protocols. And what we saw actually is that after this feedback, 98% of the centers received the highest PI score, which means that the highest quality. So we were sure that actually the study would be carried out in the right way in terms of image quality. And actually, we also saw this during the study, and when we also evaluated the quality again at the end of the study, we saw that there was a very good quality MRI. And also, especially for the DCE sequences that, as you said, are in this case, for example, the most important sequences.
And
so we evaluated,
Francesco, do you feel comfortable with that proposition I just said to Veeru, that that's it? Surely this is the end of dynamic contrast enhancement for prostate MRI. And, I certainly think it is. And in fact, I think that's the way our practice has evolved over the years. And me as a full-time prostate cancer specialist, all I do is prostate biopsy and prostatectomy. And I can't remember the last time I actually looked at the DCE sequence on an MR, because almost every MR we do a biopsy on or a prostatectomy on has diffusion restriction. That's always the best part of the sequences in my mind. But do you think it's fair to say that, or will there be people out there who say, well, I'm not sure, I still personally find that DCE has made a difference to my patients? How do you think it'll be received?
So we also have to take into account an aspect here. I mean, I agree with you. We are ready to look at the future and basically consider to skip contrast. I agree with that. Provided that the quality, as we said, is good. But for example, if we have a patient with artifacts from a hip replacement, for example, we know that the diffusion with imaging will be very flawed by these artifacts. So DCE in this case can act as a safety net. So we should also take into account these things when we scan our patients. So for example, if you have a patient with hip replacement, then you should scan your patient at 1.5 rather than a 3T to avoid the presence of more artifacts, for example. And in that case, you should also be ready to inject contrast if the diffusion with imaging is non-diagnostic. I also agree with you actually that T2 and diffusion with imaging are the dominant sequences, right, for the TZ and the PZ. So DCE has only a role to upgrade the parastry in the peripheral zone. So so it's not a dominant sequence, but we should still think that, in certain cases, like for example, diffusion with imaging followed by artifacts, DCE should be carried out. And the other thing we should consider also is if you're planning to treat our patients with focal therapy, for example, or other treatments, we also have to have the baseline with DCE sequences. So this is much better when we compare the post-treatment scans. But I agree also with Veeru saying that we are there now to move to the next steps and consider biparametric MRI, yes.
I love it, Veeru, because I think what Francesco has just said, that yes, across the board, that's going to be it, biparametric. However, he's listed a bunch of individual circumstances, which we all fully understand. I want to go on and talk about, what the impact of this might be on active surveillance, for example, or for assessing recurrence, because we've still understood that, although we use PSMA for recurrence, that perfusion enhanced imaging can help for recurrence. But before we go on and talk about those other circumstances, just to clarify, you define clinically significant cancer as grade group 2 or above, I think. Is that right? Or any amount of grade group 2? Just remind us of what your definition of clinically significant cancer was.
Yeah, you're exactly right. That was our primary definition, any grade group 2 or above. We did explore a secondary definition of any grade group 3 or above, which had consistent results as well. And that was actually the beauty of the within patient design, because it's quite a powerful design. You can explore those sensitivity analyses and the results can still be valid.
Were there any subgroups that you've looked at yet where you might have identified that the DCE made a difference?
We haven't looked at any subgroups specifically, but given the difference was so small, we're talking about 0.4%, it's unlikely that any subgroups will show a difference.
It is quite amazing. And I noted as well that, what the average PSA was around 5.6, 88% impalpable disease. So this is actually a slightly more favorable disease group than the precision trial, if I recall. So I think that's what it's highlighting, is this is really the group where MR makes a huge difference. We're very heavily dependent on MR, and notwithstanding that, you drop the contrast and you still have almost identical detection of clinically significant cancer. So I think it's a no-brainer. That's it. Game over for gadolinium. It certainly will be from my practice from tomorrow. I'm going to write on the front of every MR form, biparametric only, please. I'm sure there are people out there listening who might go, I'm not sure, Declan, but am I crazy, Veeru? Do you think urologists will, and do you think guidelines will look at this and say, yeah, there's been some evidence already about biparametric, but surely this prime trial in JAMA is going to be the one that really makes a strong difference to recommendations?
Yeah, I would certainly never say you're crazy, Declan. So look, I think we designed PRIME to address some of the limitations of those previous studies. In general, the previous studies and the systematic reviews were in favor of the same message. The limitation were that there were smaller studies, some of them retrospective, some of them without targeted biopsies, without quality control, to the same degree as we did in the multicentre study of PRIME. We specifically designed PRIME to try and give contrast the best chance of showing a difference. That's why we optimize the contrast sequences beforehand. So, in this multi-center setting, we have level 1 evidence showing that biparametric MRI is as good as multi for clinically significant cancer detection. So I would suggest that this will make its way into the guidelines at the next review.
I'm sure it will. Francesco, we want to also talk about what the future will be for the use of MR in other settings. Let's talk particularly about active surveillance. So I know in your centre at UCL, it's very typical for active surveillance patients to be almost completely dependent on MR, and biopsies are often not done. Veeru can correct me if I'm wrong. Biopsies are not done per protocol if the MR is stable or normal or whatever. What is going to be the impact of the PRIME trial on our use of MR in settings like active surveillance, do you think?
So we recently published an updated paper on the results from our MRI-led active surveillance cohort at UCL with more than 1,000 patients. And we have seen basically that we can use MRI to monitor patients on active surveillance. I'd really think actually that PRIME might make a difference. And we already have some colleagues in some centers, especially here in the UK, that are already doing biparametric MRI for active surveillance. We personally don't do that. We are still doing multiparametric MRI with contrast, but of course, as radiologists, we're very open to the possibility to have this as a biparametric approach. As we said at the beginning, actually, so now we are going to use actually MRI for active surveillance, focal therapy, but also maybe in the screening set, there are some studies going on in terms of using MRI as a screening tool. So the number of MR scans that we will see that will be performed in the future will be much higher. The other thing is that we need skilled radiologists, as we said, good quality MRI, but we also need infrastructure. So if we are able actually to shorten the MRI scans to a biparametric approach also in the active surveillance setting, for example, this will, give us more room to do MRI for other settings. So I think this is definitely something we need to consider in the active surveillance setting, although we don't have any evidence at the moment that we can skip it. But, we're building that.
Surely it's common sense, Veeru, isn't it? If if a patient's been selected based on MR and biopsy to be suitable for surveillance, and MR is going to be your main tool in your centre, I mean, how often is it only the DCE that reveals a reclassification in the MR, in the active surveillance patient? And especially, as Francesco said earlier, these are patients not having one MR, they're having serial MR over a few years. There's even more reason why we should be trying to drop the gadolinium.
Yeah, well, I do agree with you, Declan. Of course, we should only make conclusions in the group of patients which were studied in the prime, but of course you can make generalizations to other groups. And as Francesco said, we're producing our up-to-date data on that. So yeah, I agree, it can be used in some other settings, and it makes sense. I think Francesco highlighted the increased demand of MRIs. If I give you an interesting fact, when prime was being set up, work from the US showed that only a third of patients are getting a prostate MRI before a biopsy. And with the Lancet Global Commission showing cases of prostate cancer are going to double by 2040, and with the number of cases now having active surveillance, which is MRI led, you can see all these MRIs, as Yele Berens would say, a tsunami of MRIs. And the only way to make this feasible would be adjustments like this. So this is why I think this is an important drug.
Now, I know at the end you want to acknowledge your authors, especially the youngsters I see, first and second authors who I know because I've met them and they've been on the podcast before, and your funders and your patients. I do want to ask you a bit about that because I know you have interest in using AI, for example, to help interpret MR. So that could be one other way of trying to cope with the tsunami of MRs, apart from dropping the gadolinium is, embracing other technologies to try and improve workflows and so on. Or second, using lower field strength magnets. And I know that's something that's of interest in the kind of MR for screening setting, office-based MR, small machines that will just give a basic read and then be a triage into a biparametric MR. So can I ask you about those two settings, Veeru, using AI and your ongoing work in that area, and perhaps smaller or more boutique MR that might allow us to scale up the number of MRs we will need?
Yeah, so I think using AI is a really important area to explore. It's one of the things that we suggest in the future work for the paper. With the large number of MRI scans, we need equally a large number of experts to report these. And people like Francesco don't grow on trees. They take a long time to train. So in order to try and replicate some of that expertise, AI can obviously learn and read from lots of scans and produce quite high performance. And we saw that from the PI study, which was published in Lancet Oncology. So we're leading a new trial called Paradigm, which is going to evaluate whether AI in this same setting of patients has value in detecting significant cancer. And this will be a multi-center within patient international study like PRIME. And we hope that that will shed more light on that area. With regards to low field magnets, I can't really comment too much on their use because I haven't seen much data on it, but maybe Francesco might want to comment on that.
Yeah, so in terms of low field magnets, basically, I do really think we are not there yet. So we should keep on using a 1.5 or 3T as the Paris guidelines suggest. So usually we use the mpMRI for example, scans like MSK, for example, for the knees or for the shoulders. I think actually that in the screening setting, as we were discussing, we should not try to do this on lower field scanners, but actually try to streamline even more the sequences that we are using. So having even shorter sequences, there can be only just 2 sequences, just 2 acquisitions, only AXA, for example, that will help us to see if there are any big lesions that need to be further investigated with a full biparametric or multiparametric MRI. So I think actually that we should not diverge from the use of a 1.5 or 3T. Bearing in mind again that 1.5 should be used when you have a patient with metal work. And in terms of the AI, I totally agree with Veeru. So as you said, we are already carrying out our new studies on AI. And from a radiology perspective, actually AI is quite exciting because as we said, we have a huge increase in terms of the MR scans, and also we need skilled radiologists, and AI might help us I'm not saying that they are going to AI is going to replace us as radiologists, but it can be really helpful for us. And just one thing from the radiology world, basically from the European Society of Urogenital Radiology, the SUR perspective, we are also working on this in terms of providing the radiologist certification accreditation in prostate MR reading, because we really need to have highly skilled prostate MR radiologists if we want to do that right, in addition to a good quality MRI. So we are also working on that.
Excellent. So he's not too afraid of being replaced by AI. That's good to hear. Good to hear, Francesco.
Hopefully I'm not proven wrong.
Isn't that what they say? AI won't replace you. It'll replace the people who don't use AI, etc. in the workplace. I didn't know that before, that if you have a patient with a hip replacement, for example, you're better off scanning them on a 1.5 Tesla machine, if I heard you correctly, and consider contrast enhancement. But I didn't know that, but it's hard to find 1.5 Tesla machines. I must say all the machines in my building are all 3 Tesla machines. And I suppose if you have them side by side, that's okay. But it's difficult to find a 1.5 machines in the cancer centers, I think, for sure. But, now, Veeru, back to you. And finally, I know you do want to acknowledge all the people who made this trial happen in the first place. Your authors, your investigators, your funders, your patients, and so on. So over to you, because you ran this during COVID, if I read the dates correctly. So it wasn't easy, I'm sure.
Yeah, this has been, I think, almost now a 7-year labour of love. When you put the application in for funding, that was actually peri-COVID. We were given the funding award by Prostate Cancer UK, and because of COVID, they were having challenges in raising money to meet the successful funding bid. So John Black Charitable Foundation stepped in and helped out Prostate Cancer UK, and together with a little bit of help from the EAU Research Foundation and Wolfgang Diekmann, they thankfully funded the study. And the recruitment period was during that kind of peri-COVID time. And really it's thanks to the investigators around the world in those 12 countries who really thought this study was important to try and recruit those patients, again, finishing recruitment within 18 months, kind of record-breaking time. And we must thank our patients who agreed to be part of this study, and without whom this would not have been possible at all. And they helped to develop the study, the design of the study, and the dissemination of the study will be part of their remit too. So I'm very grateful to all those people. A particular shout out to our 2 first joint authors, Alex and Aqua, who have worked tremendously hard on this study for the last 7 years as well.
From when they were medical students, if I recall correctly. Yeah, quite extraordinary.
Absolutely.
Absolutely fantastic. It's lovely when you get sent this paper and realize, well, there you go. That's a practice-changing trial, immediately with immediate effect. In my view, this is certainly what I'm going to do in our practice here. As of today, I'm going to write biparametric on the top of the vast majority of MRs that I'm going to request in the early detection setting. So it is a great tribute. Well, thank you to you two in particular, Veeru and Francesco, but to all the authors, all the patients. You've made a big difference, because I believe this will change practice, like effective practically immediately, and certainly once we see it percolating through in guidelines over the next 6 months. So Francesco, thanks very much for joining us. We love having this multidisciplinary approach to these challenges, and to you and all your MR colleagues, and Veeru, to you and all your urology colleagues and your funders and your patients. Big congratulations from us here in Melbourne and everyone at GUcast.
Thank you, Declan.
Thank you.
Wonderful. Well, that's all we have time for on this episode of GUcast. Thank you very much for joining us. The links are in the show notes to the full paper, the full prime paper published today in JAMA, no less. Very popular magazine, a very high-ranked, high-impact factor journal in the US. We'll be back soon with some more content. Thank you very much for joining us.